When trauma leaves the body unresuscitated, the entire system stalls. And when the vascular system stalls, the patient dies. Look at this clinical dashboard. On top, the blood pressure reads as perfectly normal. On the bottom, however, tissue perfusion is plummeting. This reveals the actual nature of shock, a state of systemic low tissue perfusion. To survive, human physiology requires an uninterrupted supply of oxygen to maintain aerobic metabolism at the cellular level. When tissue perfusion drops, that oxygen delivery is cut off. The body is forced into a metabolic shift from aerobic directly to anaerobic metabolism. Shock is a microscopic crisis of cellular starvation. It begins long before it ever manifests as a macroscopic dip in a vital sign. Delaying treatment creates a secondary trap. When clinicians finally restore oxygen delivery to starved tissue, it triggers a massive reperfusion injury. This injury progresses into systemic inflammatory response syndrome, or SIRS, as the immune system begins attacking the body's own damaged tissue. This inflammatory cascade culminates in multiple organ failure, systematically shutting down the lungs, kidneys, and liver. Once 2 or more organs fail, the mortality rate reaches approximately 60%. Early diagnosis and rapid resuscitation are the absolute only barriers preventing this fatal cascade from executing. To understand organ failure, we have to look at the microscopic bedrock of the body, the single cell. As perfusion drops, oxygen levels at the cell membrane plummet to zero. Lactic acid builds up as a byproduct of anaerobic metabolism, turning the cellular environment highly acidic. This specific acidic buildup is exactly why clinicians track serum lactate and base deficit in trauma patients. They are direct measurements of microscopic cellular starvation. Without oxygen-derived ATP, the cellular infrastructure fails. The sodium-potassium pump on the membrane completely halts. Without this gatekeeper, sodium ions flood uncontrollably into the cell's interior. Driven by osmosis, water follows the sodium, rushing through the membrane into the intracellular space. The affected cell swells uncontrollably under the intense osmotic pressure, stretching until the outer membrane violently ruptures, and the cell ultimately lyses. This localized cellular death, multiplied by billions, is the microscopic engine driving macroscopic shock. This destruction quickly expands from the individual cell to the surrounding capillary network. The acidic, hypoxic environment injures the endothelial cells lining these blood vessels. As these vessels lose their integrity, they leak fluid directly into the interstitial space. Simultaneously, cytokines and free radicals are released into the tissue. This results in profound tissue edema. The swelling physically compresses the remaining healthy vessels, further choking off oxygen delivery. Now, the body's own microvasculature begins destroying the very tissue it is meant to feed. This chart shows why shock is easy to miss. Top, blood volume. Bottom, heart rate and blood pressure. As volume drains, sympathetic activation drives extreme tachycardia. The heart rate line spikes, but notice the blood pressure. It remains perfectly flat. Meanwhile, the kidneys vasoconstrict to preserve central volume, causing urine output to drop immediately. Spikes in vasopressin and cortisol further clamp down peripheral blood vessels to protect core organs. This is the novice trap. The tank is half empty, but because of these compensatory mechanisms, the blood pressure stubbornly remains normal. This is compensated shock. At this stage, clinical stability is a dangerous illusion. If the patient takes beta blockers, the drug masks early tachycardia, completely removing the primary warning sign. Once the compensatory mechanisms fail, the blood pressure crashes. The patient has entered decompensated, potentially irreversible shock. Waiting for hypotension is equivalent to waiting for the patient to start dying. Blood pressure is a fatally lagging indicator. In trauma, the primary driver of this entire cascade is hemorrhage. This schematic shows the mechanical reality. Hypovolemia reduces preload, which crashes cardiac output. A core surgical axiom is that hemorrhage and shock are not synonymous. Hemorrhage is the cause, shock is the systemic consequence. Clinicians must classify the bleed by visibility. Is it revealed and external, or concealed within a body cavity? They must also classify by timing, primary, reactionary, or secondary. Stopping the source of volume loss must accompany volume replacement. Otherwise, you are simply diluting the blood and fueling a coagulopathy. The resuscitation protocol is non-negotiable. Secure the airway, apply oxygen, and establish 2 large-bore IV lines. You then provide a fluid challenge and categorize the patient based entirely on their hemodynamic response. A transient responder shows initial improvement but rapidly degrades, indicating severe, ongoing internal loss. A non-responder fails to improve at all, signaling catastrophic active bleeding or the onset of acute traumatic coagulopathy. For these critical non-responders, the trauma team requires an immediate fast ultrasound scan to rapidly locate the exact source of concealed internal bleeding. Concurrently, the clinical team must activate the massive transfusion protocol to replace clotting factors alongside volume. Success requires continuous monitoring of heart rate and ECG, with a specific focus on urine output as the window into organ perfusion. Effective resuscitation breaks the lethal triad and restores perfusion at the cellular level, pulling the patient back from the brink of multi-organ failure.